Dr. Zena.
Thank you. Hello, everyone. So I would like to tell you a bit about the story of our institute and how we evolved over time to become a center of excellence for theranostic. So I am also a consultant for Elite, which is a radiopharmaceutical company in Belgium. And when I presented first, I was presenting about one specific institute, Institut Jules Bordet. However, we are part of a group of hospitals. So I like to tell it a little bit like a story. So in a kingdom far, far away, once upon a time, there was a regroupment of 3 hospitals. A university general hospital, which is, oh, my laser doesn't work, so the Hôpital Erasme, our Institute for Oncology, Institut Jules Bordet, and also a pediatric center for care of our small patients, our children. And these are all located in Brussels, the center of Europe. We are all centralized in a few kilometers from each other. So I will give you an overview on how we started in this oncological center, Institut Jules Bordet, with the start, how it started with theranostic, what were the challenges and opportunities that we faced, and the future, which I think is already now. So this is the whole milestones that we've known with theranostic. So we have a whole evolution, starting from how was said this morning by Dr. Munir, the introduction of iodine 131 for the treatment of thyroid cancer, but not only, also the investments that have been done along the way with more specific molecules that were recognized targets inside your body. And you see in red, all the red parts is where Bordet, Institut Jules Bordet invested and introduced these techniques in Belgium. So we are quite pioneers in this part of theranostic. We were strong believers from the beginning that this would change and revolutionize the cancer treatment of our patients. And we did several first of Belgium for the gallium introduction as first in Belgium, the introduction of lutetium, dotatate, own production in Belgium as a first as well, etc. So this took time. I started actually in 2009, and so from 2009 forward, these were all introductions that I personally was involved in. This image was published a few years ago, where we saw that actually the nuclear medicine field is changing. There is a real evolution where we go from our diagnostic nuclear medicine that we were all used to a more therapeutic part of nuclear medicine. And we see this the evolution as a major part of the interest also of the industry in our field. Our field is changing, and we need to face it front on. So what are the major challenges that we faced and the opportunities? First of all, again, we are here all for the patient. Our primary point, our central point is the care of the patient. It should always be central. We also want to be sure that we have better imaging and better treatment to treat these patients. And this comes with some challenges. We really need now dedicated knowledge for our radioligand therapy. So we need radiobiology specifically for radioligand therapy, and not what we have now, which is the extrapolation of external beam radiotherapy radiobiology. And also dosimetry will play an important role, I'm sure of it, in the few coming years. We need advancement in the radiopharmaceutical field, so new radionuclides, new tracers, new ligands. And also there is a whole evolution because we have all this new regulation in terms of the GMP regulation or PICS, for example, in Europe. And this faces some challenges because our infrastructure of the old nuclear medicine department are not made to evolve quite rapidly on these changes. But also everything based on collaboration. In Belgium, we say that unity makes strength. And this is really our motto for Belgium, where we think that when you collaborate with others, you can advance much further. And we have common projects with different countries and also different instances all over the world to try to advance in this field. So one of our major challenges was actually our infrastructure. This was our old facility. We were situated in really a nice, really in the city center of Brussels, nearby the South Station, nearby close to beautiful shops and restaurants. However, it was really small and a really old building. And because of that, we had a small lab where we could do our radio tracers and only 2.5 metabolic rooms. 2.5, why 2.5 and not 3? Because we had one room that was not connected to tanks. It was connected with refrigerated toilets. So it was all a hassle also to handle this waste of the patients. So the good news came in end of 2021 with a move to our new building, beautiful building. If you have the time or the possibility to visit us in Brussels, you're more than welcome. It's a beautiful building that is situated in the campus nearby the General University Hospital, but also the medical faculty of our university, and in a whole green neighborhood. And we have had the possibility to invest in the infrastructure to be able to make our new radiopharmaceutical, but also to treat our patients better. So we had a new whole fleet of state-of-the-art imaging with new PET CTs, SPECT CTs, even the new SPECT CT that is now from GE. We were the first one to have the Aurora placed in Belgium. And we do a lot of things to try to collaborate also with industry to make it better for us, for our use, for the theranostic approach. We have dedicated rooms where we treat our patients. We do around about 250 PRLTs, so with lutetium PSMA a year, and 70 PRRTs, so with lutetium dotatate a year in neuroendocrine tumors. We have 5 metabolic rooms and 1 room that is specifically dedicated, if we would need to, in the future, to treat pediatric patients, with an adjacent room where the parent can stay over without being irradiated. But also, we strongly believe that when you want to evolve and be a theranostic center of excellence, you have to invest as well in the beginning. And the beginning is the preclinical research. What do you do in clinical research? You will try to advance in combination of treatments, or even try to find resistance mechanism, or try to evolve with the new radiotracer that are at hand. So we have, in the same building, really in the hospital, a unit dedicated to theranostic research in preclinical way, and it's called ATHENO, Advanced Theranostic for New Oncology. And we have a lot of investment as well done in the clinical research trials. So we have a whole nuclear medicine clinical trial ecosystem stated and really based in the nuclear medicine department of our hospital, where we do the phase 1, phase 2, and phase 3 trial. We really conduct them in-house ourselves. We have academic trials as well. And so what we really believe is that all these partners, because nuclear medicine is multidisciplinary, we should have radioprotection, nuclear medicine physician and technologists, study implementation, nuclear medicine coordination, medical physics, and of course, radiopharmacy. But I'm a little bit biased because I'm the director of the radiopharmacy. Also, what we propose, because we were talking about training just before Dr. Omar was talking about training, we actually have a specific training of 3 months to teach to doctors from all over the world theranostic and how we do it in our institute. So it's a 2-month program, and we already received 11 nuclear medicine specialists that were trained in our institute to perform theranostics through the EIA. So it's a sponsored training by the EIA. And now we want to not only do it for nuclear medicine specialists, but also for radiopharmacy specialists and also medical physicist specialists through an EIA program as well. So we hope that it will start either in end of the year 2025 or beginning 2026. So we have had these challenges and these opportunities to invest in all of these parts of what could make us a theranostic center of excellence. And this is the future, or this is actually now. This is a patient that we treat. I always like to show this image because an image says more than 1,000 words. And we see that for a patient that we treated in our institute that had really extensive prostate cancer disease, metastatic disease, with a PSA of over 4,000. We treated with lutetium PSMA. We make our own lutetium PSMA in-house, so we prepare it ourselves in our department. And you see actually in the between the lutetium images in the red box. And this is interesting because these images really look like actually PET scan images. And this is what we could do with the star guides that we have in our institutes, really nice images of lutetium PSMA. We gave actually a patient 6 cycles, and at the end you can clearly see that the patient had a reduced PSA, but also on the image you can clearly see that the patient was quite well responding. What we are now putting in place is actually the radiotheranostics life cycle. It's what we think would help us to evolve in this treatment. So you know that there is a whole development for this radiotheranostics. We start with a target, then with a molecule. The molecule is radiolabeled. When it's radiolabeled, you will test it in vitro on cells, in vivo in small animals, and then in vivo in patients, because our aim is to help patients. But afterwards, we can get this information from the patient and go back either to the in vitro testing or even to change the radionuclide or go back to the molecule to try to optimize and make it better so that our patient can benefit the most of these treatments. And we can then try as well, we are doing now a study that we call the preclinical, which means that we will actually make small models of our patients. We will take a part of the tumor of the patient and test combination of treatments, similarly that we would test in patients. However, we can test simultaneously different combination or different dosages so that we can evolve with that patient specifically with his own tumor characteristics. So our objectives for the future are new treatments and combination, new indication, and new knowledge. We want to regroup all of that on our institute to be able to propose innovative possibilities of treatment. We tried new indications. We have academic studies in multiple myeloma and breast cancer, triple-negative breast cancer, with radiotheranostics at the moment. And we want to acquire new knowledge because with the new knowledge, we can better the life of our patients in the future. One point that we are investing also in our institute, and we evolved quite a lot in the recent years, is the creation of our international patient cell. So we have now a dedicated unit in our institute to try to promote this treatment for patients all over the world. They can come to our institute, they can be treated in our center with all our skilled personnel. So you have all the contacts here, and we are also at Arab Health, so you have the booth Z1H37A, where you can find us till tomorrow, because we will close tomorrow. And if you have any question, we have our directors here from the hospital that are also present if you would like to collaborate to be able to treat your patients in Belgium. So to conclude, we have had an evolution of radiotheranostics over the years. We have now in Bordet incredible infrastructure and talent. We collaborate inside and outside of the country, and it's always all centered around the patient, because this is why we do it for. This is our main goal, to help the patient. So the journey is on, and I thank you all for your attention.